and make sure that you're getting at least the standard of care biomarkers tested from your tumor, because it really does make a difference if you happen to have one of these targets. I'm Dr. Samuel Klempner. I'm a GI medical oncologist focused in gastric and esophageal cancers, and I work at Massachusetts General Hospital in Boston. The first responsibility for us as GI oncologists is really to get as much information as we can so we can make our best estimate of what the clinical stage is. And that's based on scans and biopsies and endoscopic ultrasounds to really get as complete of a picture of where the disease is as we can, because that ultimately informs several key aspects. One is, are you going down a curative intent pathway with the goal of eradicating everything prior to a surgical approach with the goal of long-term cure? Or unfortunately, in our metastatic patients where disease has spread to other organs, the approach is long-term disease control and palliation of symptoms with the goal of improving survival and balancing quality of life. So the approaches are quite different, and there's a lot of nuances, including, the use of biomarkers and additional testing we do on the tumor to help guide our treatments. Tumor markers and biomarkers are a little bit different. Tumor markers are generally proteins in the surface of cells, including normal cells that exist in higher concentrations in the presence of a cancer. So with gastric cancer and esophageal cancers, the most common tumor markers are usually something called CEA and something called CA19-9. And these are blood tests that have a normal threshold, and people who have a protein level above that threshold would be considered to have an elevated tumor marker. And it's sort of a very crude measure of the burden of disease and something you can track over time to see, if someone is responding and you're killing tumor cells, in theory, that number should come down. And it's a nice complement to our other studies like imaging and symptomatic improvement. Biomarkers are a little bit different because they help us guide actually treatment decisions. So these are features of the tumor or features of the immune system sometimes that may tell you how likely a patient is to respond to a given therapy, or may tell you a little bit about the disease biology itself. I would like to mention the importance of biomarkers and the ones that we consider sort of the bare minimum, and also the role for more extensive testing. Just like if you were buying a house, you wouldn't buy it without seeing it. You would have your inspection and you would take a deep dive. I like to think that if I had a cancer, I would think about it the same way. To do that, there's sort of a bare minimum. In patients with stage 4 disease, that's HER2, which is a surface protein. That's PD-L1, which is a surface protein present on tumor and immune cells. And then it's something called mismatch repair or microsatellite instability. These are all things that are very important because they will guide some treatment options and sometimes have exceptional outcomes. So we do this with DNA sequencing from biopsies, and increasingly we're doing it with DNA sequencing from the blood. Because remember, if you take a biopsy, you're only getting a little snapshot of what's in that biopsy sample, but there may be multiple areas of tumors that are slightly different. And so all these things are shed into the blood. And so the blood might be more of a global representation of what's going on in the tumor. So for all of our stage 4 patients, we try to do sequencing off the tumor biopsy, but also from the blood, with the goal of not only getting the standard of care biomarkers, the HER2, PD-L1, and MSI, but also multiple other proteins, which may open the door to other therapies, including clinical trials and sometimes off-label therapies. All right, so we talked a lot about the kind of standard of care biomarkers, but how do we use this? What's the new data that's out there? And then even what are kind of some of the nuances within biomarkers? I'll start with HER2. Again, this is a protein on the surface of tumor cells that's overexpressed in about 15 to 20% of our stomach and esophagus patients. And that's important because we have therapies that we know improve survival when we target HER2. So there was an older study called TOGA. Half the population got a HER2 therapy on top of the chemotherapy. And sure enough, people that got the biomarker-directed therapy, they had a longer survival. So for some years, that's been our standard. And one of the things we've learned is that, the biomarker may come in various levels. So you might have a HER2 that's really, really highly amplified and overexpressed, Or you might have one that's a little bit more mixed, and those tumors behave somewhat differently. In general, the very, very highly amplified patient having some of these exceptional responses to HER2-directed therapy. Based on a trial, a big study called Keynote 811, we got a new tool in the toolbox. And this was a trial asking another kind of simple question, which is, take the standard, which was chemotherapy plus the HER2-directed therapy, and add immune therapy on top of it. We saw that the response rate, the number of patients who had a decrease in the tumor burden, was significantly higher when you added the immune therapy on top of the targeted therapy. And this really matters for our patients because when people are symptomatic from their tumor, they can't swallow, they're having pain, a 75% chance that their tumor is going to shrink is meaningful because that usually comes with improvements in swallowing and improvements in pain control and greater ability to tolerate therapy and nutritional support, etc. Although it's really important to give patients the best drug to have the best chance of response and survival, it's equally important to avoid a drug in a patient that's unlikely to help them and may in fact add a bunch of side effects. PD-L1, this surface protein expressed on tumor cells and immune cells, that it seems that patients who have higher levels of this protein, and this is done by something called combined positive score or CPS testing, people with the highest scores are seeming to derive the greatest benefit from these therapies. So there's been some key studies. One is called Keynote 590 and one is called Checkmate 649. And these are very large trials that were asking another relatively simple question, which is, add immune therapy on top of chemotherapy, do you improve the survival of patients? And importantly, does it matter about the PD-L1 status? And actually what they saw is consistent between the two studies. Broadly, chemotherapy plus immune therapy does improve the survival for the PD-L1 positive patients. And really it's the upper positive patients, the CPS score greater than 5 and greater than 10 are the people who are really driving the benefit here. If you look at the populations of people who don't have the biomarkers or have it in a low level, those patients also don't clearly benefit. There's a lot of other cool and interesting biomarkers that are coming, Claudin 18.2, EGFR. There's a kind of a bright future in my mind for gastric and esophageal cancers.